Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Colin Richman was born and educated in Johannesburg, South Africa, and currently maintains a private practice of periodontics and dental implants in Roswell, Georgia. In this episode of Practice Inspiration, he shares information on the pre-orthodontic and restorative periodontal augmentation.
Good morning, or good afternoon. Thank you for this opportunity to share a few moments describing POPper and PREPper. So the questions are, why are orthodontic problems and gingival recession so prevalent in the United States and in other New World countries? Number two, can these issues be prevented? And how about breathing disorders, impactions, and unsatisfactory aesthetics? And why don't we see these problems in the animal kingdom and in native communities? So my journey starts in 1981. I'm a recent graduate out of the periodontal program. I've opened my practice and I'm waiting for a referral when the local orthodontist calls me and says, Colin, I have a patient for you. He tells me he debanded this patient a few weeks ago and now she presents with extensive gingival recession, loose teeth, and could I just grow some tissue and bone? In 1981, of course, that was a terrifying thought. We had no idea of what to do, and I tried to handle that patient appropriately. My fear when I saw this lady was, what is the longevity of this dentition? However, today, so many years later, we know that by taking a similar patient and a similar case, we can enhance and augment the gingival tissues using hard and soft tissue agents and have a terrific long-term predictable outcome with minimal recession and with minimal future relapse well documented. What are some of the problems and the iatrogenic factors that are associated with orthodontic therapy when they occur? Well, to simplify the issues, I've created a little mnemonic called 4 R's and a D. The R stand for recession, relapse, resorption, rejection of orthodontic treatment, and then the D is decalcification. And as this is a very brief program, we know from numerous studies and the terrific meta-analysis of Renkema that there is substantial gingival recession associated with the decrowding of the crowded dentition. I bought myself a CBCT scanner many years ago, and I started documenting in detail and then published an article clearly showing that gingival recession, the fundamental primary factors are associated with osseous dehiscences and fenestrations. Now, the question is, why in New World countries do we see these issues? And in order to try to answer this, I have been looking at books of human anthropology, texts of anthropology over the millennia of the head region, and looking at the genetics of tooth and alveolar bone development. Because we know, and we are seeing more consistently, again in New World countries, that this is a familial trend. I treated the daughter, then I treated the daughter's daughter, and now I'm treating the daughter's granddaughter, and it seems that with each generation, these issues are becoming more and more pronounced. And it transpires, the bottom line of the story, this is a fabulous study on human anthropology of the head region, and it transpires that as time goes by, when in previous millennia we would be out in the bush looking for lunch and then hunting for our lunch and killing our lunch, we needed and we had great, big, strong, profound jaws because that's how we survived when we needed to get some nutrients off these carcasses. And then we became farmers and gatherers and utilizers of industrialized food production. In the New World, women have decreased the amount of breastfeeding, and the consequences of that is that we are getting brighter, and our brains are growing, and our crania are growing at the expense of our face. And so what we are finding is that our alveolar processes are fundamentally shrinking. But when we look at tooth development, we know that teeth are governed by genetics. And so if we take, for example, again in the New World environment, for example, a great big football player, in my world it would have been a great big rugby player, and for example, a little teeny weeny petite ballerina, and they produce a kid with his bigger teeth in her smaller jaws, indeed we've got a problem. And the problem is that if those bigger teeth are now being put into yet smaller shrinking jaws, we end up with these factors of crowding, thinner alveolar processes, sleep disorders due to inadequate tongue space, etc., 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 and impactions. And again, as a reminder, I've been looking at many animal jaws, mammalian jaws. I've been looking at ancient skulls at various locations, including in Africa, including in Alaska. And we, for example, in the carnivore, we never see any crowding and or impactions and or fenestrations and dehiscences. And in the herbivore, as one example of about 350 data sets that I have, we don't see the same issues. But our lifestyle is governed around this type of environment and other factors. So the question is today, do we have preemptive therapies that will reduce or even eliminate the risk of these 5 potential iatrogenic complications that are frequently encountered in New World countries and in orthodontically treated patients, the 4 R's and a D that I mentioned? We're going to look at just a few cases because time is limited. But how do we identify the risk for these patients prior to initiating, for example, orthodontic therapy or reconstructive therapy? Ideally, of course, one should be taking routinely a CBCT scan and looking at the alveolar bone structure relative to the width of the tooth. Notice again in the sagittal plane the discrepancy between tooth width and alveolar bone width. In the reformatted image, we see this. But the poor man's CBCT is the index finger. Simply run the finger along the root eminences, and if one feels prominent root eminences, potential risk is there. Here's the same patient looking at her prior to my treatment. Root eminences are prominent. At the time of surgery, note dehiscences, note fenestrations, and in that decrowding of that crowded dentition, what is the risk for future problems? A few more cases to illustrate the point. Here we see a patient referred to me, one of my very first patients when I treated, in those days we termed the treatment concept Wilcodontics or periodontally accelerated osteogenic orthodontics. For many reasons I don't have time to elaborate in this program, I have renamed it POPA, as in Pre-Orthodontic Periodontal Augmentation. Patient is referred in, you can identify significant gingival recession. Obviously underneath that we know there are dehiscences, there's crowding, there's periodontitis associated, 6 to 8 millimeter probing depths. We've got crowding, she's unhappy with her aesthetics, and for social reasons she would like her treatment completed yesterday, which many patients would prefer. I went ahead and treated this patient with substantial augmentation corticotomies and both hard and soft tissue grafting agents. And here we have the lady about 4 or 5 years later. Notice the reconstructed mucogingival complexes. Notice what we had at the time of surgical treatment in terms of dehiscences. You'll notice the corticotomies, which set up the wrap effect, which facilitates much more rapid tooth movement. But the thrust of these procedures, in my opinion, is the fact that augmentation processes and procedures are needed. Let's look at, as my practice is evolving and our local community orthodontists are becoming more familiar with this risk for future relapse and recession. As we mentioned, here's a young individual, patient who is undergoing 2-phase orthodontic treatment. Phase 1 leads to that clinical situation. Phase 1, I believe, was started at about age 9, 10. The patient is now 12, 13. He's referred in for augmentation because you will notice the substantial crowding, decrowding, and intrusion is indicated in this patient. Dr. Gray, the orthodontist I work with, has identified prominent root eminences and the risk for future problems as mentioned. Here we see the patient treated with only mandibular arch augmentation from first bicuspid to first bicuspid on the facial. Notice this robust mucogingival complex. Notice that treatment was provided in less than a year. And the exciting part of this patient's case is if we look at the pre-treatment lateral ceph, notice this deficiency of facial bone, which I am running another study, and we find these dehiscences in virtually every single crowded patient to a greater or lesser extent. Notice the post-treatment, notice the tooth alignment and orientation and the intrusion, but look at this newly generated bony complex in this patient. This is what we saw at the time of surgery: dehiscences, fenestrations, just a high risk factor associated with bigger teeth in smaller jawbones and alveolar processes. And in the reformatted pre-treatment and post-treatment, notice this newly developed bony complex for the long-term success of this patient. One other exciting issue is notice on the axial plane all of that newly generated bone. In this patient who presents with an appearance similar to what we see, notice the crowding, she has got many unaesthetic restorations. She's ready for a full mouth rehabilitation. Obviously, all of those teeth are in the wrong place and orthodontic therapy is needed. She is absolutely concerned about the risk of triangular spaces. We went ahead and treated her with localized augmentation plus other factors of treatment. When we look at the retracted image, notice these prominent tori. Notice the crowding. Notice this gingival recession. It's going to come back to haunt me in a moment. How I treated this patient was popper augmentation for the mandibular anterior segment without raising a lingual flap. We removed tori and completed crown lengthening only in the maxilla. Obviously, there's an abundance of bone there. We provided corticotomies in the top and bottom, which induced the wrap effect, which allowed tooth movement to occur much more rapidly. And then Dr. Zanstra, a terrific prosthodontist, completed a beautiful reconstruction for this patient, as we see in this lower right image. I do have, at a few years later, post-treatment gingival recession, which will be closely monitored, and the patient is aware that supplemental grafting may be indicated in the future. And the reason I show this is that when severe prominent dehiscences are evident, we sometimes need to complete a supplemental graft for these patients. And I would speculate this is about 5 to 10% of individual teeth, not of full cases. Beautiful reconstruction. Patient is ecstatic. Treatment was orthodontic treatment was completed in less than a year for a case of this complexity. Let's go back and look at a localized treatment for a teenager. She's a class 3, scheduled for orthognathic treatment. Please notice the severe crowding, the already evident gingival recession at about age 16. Notice the left buccal shot. Notice the ultra-thin bone, doing the index finger test and running the fingers over the root eminences. We feel those prominences. We grafted substantially. You can notice the end point of the graft at the bicuspid. Notice these robust mucogingival complexes. And this is 4 months post-treatment. Notice the pre and the post lateral ceph. Let's take a moment to share some information on PREPA. So POPA is pre-orthodontic periodontal augmentation, a term that we've started using extensively in our community. And PREPA is pre-restorative periodontal augmentation. Patient, as you can see, is in need of a full mouth rehabilitation. Obviously, she suffered extensive recession, and any restorative, well, prosthodontic dentist would realize these would be unacceptable amounts of tooth preparation in order to achieve a covering of those roots. Patient is now referred to me for augmentation procedures. Notice the beautiful provisionals that Dr. Zanstra has provided, but notice this ultra-thin bony structure and this very thin biotype. We went ahead and augmented using both hard and soft tissue grafting agents. I do apologize that this is not the prettiest of slides, but the issue here, of course, is that we have a patient attached to these images, and patient always comes first. Notice now the post-treatment situation. Her mucogingival complexes are absolutely robust and stable and have been for a long time. The reconstruction is terrific. We've got a jubilant, aesthetically happy and satisfied patient. We started like this. We augmented substantially, and we then ended up with both a periodontal and a dental reconstruction that is satisfying for the patient. So, in summary and in conclusion, we are moving more and more and more towards POPA, pre-orthodontic periodontal augmentation, which has as its primary function hard and soft tissue grafting, and as its secondary function, which is what patients want, the establishment of the wrap effect, which in turn demineralizes the highly mineralized bone, enabling much faster tooth augmentation. POPA is me. That's our HIPAA OSHA compliant granddaughter, and the procedure came to my mind because of my little Annabelle. So thank you so much for these few moments. It'll soon be lunchtime. I hope we have a meaningful and energy-provoking lunch, and good luck on your search for food.